This is a metabolic disease of bones presented by the SchrDbb. Reference Chemical Pathology Lecture Note of University of Cape Town by George Van der Waart AR. So here we are going to continue with the metabolic disease of bones. So the different metabolic diseases of bone consist of rickets, osteomalacia, osteoporosis, renal osteodystrophy, and Paget disease of bones. Now you need to know that what the bone has 4 important functions. 1 is structural support. 2 is that it's going to house the hematopoietic system. 3 is it's a metabolic regulator for calcium and phosphate. And 4, it acts as a buffer system because it releases the phosphate buffer in chronic metabolic acidosis. Now we go now to the first disease, which is rickets and osteomalacia. Generally, rickets occur in children and osteomalacia in adults. Is it clear? So it's defined as a defective mineralization of osteoid. There's a difference between osteoporosis and osteomalacia. Osteoporosis is loss of the is demineralization of bone or loss of the mineral part of bone. That's osteoporosis. Is it clear? And then in order to be more precise, we are going to use a certain standard deviation more than a certain standard deviation. That is 2 standard deviation. Is it clear? So generally, in order for you to have a total mark on the definition of osteoporosis, you say that it is bone demineralization more than 2 standard deviation. That's the whole and complete definition of osteoporosis. Now, osteomalacia and rickets is now defined as the loss of the bone mass. Is it clear? So when it is loss of bone mass, it is osteomalacia and rickets. Now, rickets occur in children, while osteomalacia occur in adults. And usually, the cause of rickets is because of poor lack of vitamin D. Is it clear? In case of rickets. So defective mineralization of osteoids, and that loss of, in cases you need to know that in case of rickets you have also defective mineralization of osteoids. Is it clear? So you have more of osteoid tissue in cases of rickets and osteomalacia. Is it clear? So we refer to rickets in growing bones. So in cases of rickets, you say in case of growing bones, you say rickets, while osteomalacia is in case of adult bones. So here you have defective mineralization of osteoid. Is it clear? It is usually due to deficiency of calcium. You can have deficiency of calcium, which turn due to a problem of vitamin D. Is it clear? So here, generally, you can have decreased absorption of vitamin D, like in the case of malnutrition, like in the case of malabsorption syndrome. You can have decreased production of vitamin D, like in the case of lack of UV or liver disease or kidney disease or anti-epileptic drug or alpha hydroxylase mutation. Or you can have a resistance to vitamin D by abnormal receptors. Now, rickets and osteomalacia can also be due to loss of phosphate, like phosphatouric rickets. Is it clear? We need to know that what generally in rickets you have defective mineralization of bone, and we need to know that what everything that is used in a mineralization of bone is going to cause rickets. Calcium is used in a mineralization of bone. Phosphate is used in a mineralization of the bone. Is it clear? And then the bone is going to be mineralized from an osteoid. If there is no calcium, there is no phosphate, you are going to have demineralization. You are going to have demineralization of bone. Is it clear? And then you more have osteoid. Is it clear? And generally, the hormone that increases the calcium ion level and the phosphate ion level is vitamin D. That is why rickets and osteomalacia is usually associated with lack of vitamin D. So phosphate also is also another cause in rickets. So when you have lack of phosphate, it's also another cause of rickets. So in case of high phosphatouric rickets, which can occur in chronic renal failure, which can occur in case of Fanconi syndrome, which can occur in X-linked phosphatouric rickets. Is it clear? So chronic renal failure, Fanconi syndrome, X-linked phosphatouric rickets, all of them can result to phosphatouric rickets where there is lack of phosphate. Now the next is renal tubular acidosis type 1. that's with the distal tissue, there is going to be significant loss of calcium and phosphate in urine, as the bone is going to be mobilized by metabolic acidosis. What they are just trying to say that what in a patient that has renal tubular acidosis type 1, that's the distal convoluted tubule, you need to know that what normally the distal convoluted tubules are involved with the secretion of the hydrogen ion, but in the case of renal tubular acidosis type 1, you don't have any secretion of the hydrogen ion, so hydrogen ion is going to be stored in the body. So hydrogen ion is going to displace now the the hydrogen ion is going to displace now the calcium ion at the level of the albumin. Is it clear? So when it displaces calcium at the level of albumin, it's going to make that there is more calcium ion in blood, and the high level of calcium, that's going to reduce the storage of calcium, because one of a very important storage of calcium in blood is going to be that albumin. So when there is acidosis is going to displace the calcium and reduce the storage of calcium ion in blood. Is it clear? And also the storage of phosphate ion in blood. That is going to result to hypocalcemia and hypophosphatemia later, that can predispose the patient to rickets. The clinical features generally is going to be bone pain. You have high osteoid, but you have low mineralization. So your bone is going to be more flexible because the osteoids are more flexible. So you are going to have skeletal deformity like bowing of the legs. You have deformable the skull like craniotabes. At the level of the skull, you can have craniotabes. You can have rachitic rosary with costochondral junction swelling. You can have growth retardation in children, and you can also have muscle weakness because this patient have hypocalcemia. Now, the next one, you have typical X-ray findings show generalized decalcification of bones. That's a crushed glass appearance or ground glass appearance of bones. You have widening of the epiphysis on the X-ray. That's wine glass appearance. You have pseudo fractures and subperiosteal erosions. So all those are found in this patient. So calcium level are, however, usually low or normal, or secondary to a hyperparathyroidism. So in this patient, you may see that the calcium ion level is normal because of a secondary hyperparathyroidism, but the vitamin D level is low and the phosphate may also be low. Is it clear? So the treatment is usually by giving vitamin D or the hydroxylated derivative of vitamin D together with calcium and phosphate supplementation. But the first thing you have to give is vitamin D. Is it clear? And a good diet containing calcium and phosphate supplementation. Now, osteoporosis is defined as a progressive reduction of bone mineral density. So when you are reducing bone mineral density of more than 2 standard deviation, is going to be osteoporosis. Is it clear? Now, but abnormal mineralization of bone is going to be in the case of rickets and osteomalacia. But loss of bone mineral density is osteoporosis. So abnormal microarchitecture is giving rise to weak fracture or prone bone. Is it clear? So what are the causes of osteoporosis? There are two main types of osteoporosis. You can have primary osteoporosis and you have secondary osteoporosis. Primary osteoporosis is divided into type 1 and type 2. We have type 1 osteoporosis occur as a result of estrogen deficiency. Is it clear? When you have estrogen deficiency, mostly when you have menopause, you have trabecular bone and often give rise to vertebral body collapse. So the trabecular bone, and you also have vertebral body collapse in the case of estrogen deficiency. In type 2 primary osteoporosis, it occurs when you have natural loss of bone with age. So with age, you are losing naturally your bone. So it's also going to affect the trabecular bones and also affect the cortical bones. Is it clear? You need to know that what generally the trabecular bones are the bones which are cancellous. Is it clear? Cancellous bones are also referred to as trabecular bone, the bone which are more fragile. Is it clear? They are located at the epiphysis of the bones. Is it clear? So at the epiphysis of that's why you need to know that generally a woman that has menopause can easily have fracture at the hips, fracture at the epiphysis of the bone because the trabecular bone are affected. Is it clear? And they can also have disc herniation because there's a vertebral body collapse. Now in type 2, you have natural loss of the bone with age, and also trabecular bone is also affected. That's why you can also have fracture of the hips in patients who are old age. Is it clear? And also the cortical bone affected. The cortical bone is the lamellar bone. Is it clear? Lamellar bones are also called cortical bone. They are the strong central part of the bone. Is it clear? So when they are affected, it's associated with the femoral neck fracture. Is it clear? You can have femoral neck fracture also. Now in this cancellous part, you have femoral head fracture. Now secondary osteoporosis is the next one. So in secondary osteoporosis, you have endocrine causes such as thyroid toxicosis, you have Cushing syndrome, you have hypogonadism, and diabetes mellitus can result to secondary osteoporosis. Is it clear? Drugs such as heparin, corticosteroid, chronic alcoholism can result to secondary osteoporosis. All that is immobilization, weightlessness, and all that can result to secondary osteoporosis. So the diagnosis is often only made once the patient presents with a fracture. Is it clear? Generally, we don't make a diagnosis before a fracture. We present after a fracture because the patient may have a risk factor for osteoporosis. So osteoporosis is being found. Is it clear? So the routine chemistry is not helpful in the diagnosis, as calcium and the phosphate and the alkaline phosphatase are usually normal. So calcium, phosphate, alkaline phosphatase in this case are usually normal. So you need to use bone markers have been discussed earlier in this lecture. They are principally used to assess the bone turnover state. Is it clear? So you have to know the bone turnover state for osteoporosis to monitor the response of the therapy. Is it clear? So in this case, you can see alkaline phosphatase. Alkaline phosphatase is one of the bone markers to show a high turnover state of the bone. So it can help you to know that there's osteoporosis that occurs. Is it clear? And also, because in this patient, it needs to know that what the bone is demineralized and there may be normal calcium, iron, and phosphate level. Is it clear? So in order to note it, since the bone is mineralized and there is normal calcium, iron, and phosphate level, in order to know it, you have to do first one. You can use bone X-ray, where you can do DEXA, dual absorption X-ray, dual X-ray absorptiometry. Is it clear? In order to visualize the bone density of bone. Is it clear? And then the second method is to use alkaline phosphatase. Now, the next disorder that we're going to speak about is renal osteodystrophy. Now, we need to know that it's a common disorder of bone consisting of a variable condition of fibrosing osteitis and osteomyelitis associated with chronic renal failure. Actually, what happened here is that you have a patient that has a renal failure for a long period of time. And now we know that what renal failure is associated with loss of endocrine function. So that's why the patient is going to have hypocalcemia and hyperphosphatemia. So since the patient has hypocalcemia, you're going to have that a compensation to that hypocalcemia is that what there's going to be hyperparathyroidism, and thus the patient is going to demineralize all his bone. There's going to be bone lysis. When there is bone lysis, it's going to result to fibrosing osteitis and resulting to osteomyelitis. So a combination of fibrosing osteitis and osteomyelitis occurring in a patient with chronic renal failure is named as renal osteodystrophy. Now, the next is pathogenesis. Is it clear? So what's the pathogenesis of renal osteodystrophy? You need to know that it is inability to excrete the phosphate. The inability to excrete the phosphate is the initiating event of the renal osteodystrophy. That's a major effect. You can also have hypocalcemia associated, but the major event causing renal osteodystrophy is the inability to excrete the phosphate. So the high phosphate is going to result to what? High phosphate result to suppression of the alpha-1 hydroxylase activity. Is it clear? So when alpha-1 hydroxylase is inactive, you don't have a synthesis of 125 dihydroxycholecalciferol, which cannot cause the reabsorption of calcium at the level of the gut. Is it clear? So the patient is actually losing calcium ion from the kidney, but the patient is not reabsorbing calcium ion from the gut, though the patient is taking calcium. Is it clear? This is because of hyperphosphatemia. So when there is high phosphate level, that phosphate level is going to inhibit the calcium from increasing. So that's why you need to know that first, hyperphosphatemia is antagonistic to calcium level. Is it clear? So it inhibits the calcium from increasing. So when it inhibits the calcium from increasing, it's going to result now to osteomalacia. This one is the case where you have osteomalacia. Now, in case of chronic acidosis, it's going to promote the demineralization of the bone, because you need to know that what? We need to know that hydrogen ion causes the decalcification of the bone, and the second reason is that there is demineralization with acidosis because the phosphate is going to act as a buffer system in cases of a chronic acidosis. Those are the two main cases that can result to demineralization of bone. Now, the next case is that what you can have hyperparathyroidism. Hyperparathyroidism is going to result due to hypocalcemia. Is going to trigger the increased bone resorption. Is it clear? In order to raise the serum calcium ion level. And now the parathyroid hormone is going to result to bone lysis. And hyperparathyroidism with parathyroid hormone, since it results to bone lysis, is going to cause now the osteitis fibrosa cystica. So with the osteitis fibrosa cystica of the renal osteoid dystrophy is due to the hyperparathyroidism. Why osteomalacia is going to be due to inhibition of the alpha-1 hydroxylase activity, just such that the vitamin D cannot act. Is it clear? Now, the next case is a case of osteosclerosis. Osteosclerosis is going to be activated by hyperphosphatemia, where you are going to have that is going to be due to the renal inability to excrete phosphate. Is it clear? So the renal inability to excrete, if the solubility product now of is going to exceed, when the solubility product exceed the 4.6 that we know, you are going to have osteosclerosis of the bones. Is it clear? So if the solubility product exceeds the 4.6 that we have seen above there, we are going to have osteosclerosis. So now the biochemical, what is biochemical? The patients, biochemically, this patient have a low normal calcium if the secondary, with secondary high parathormone and hyperphosphatemia. Is it clear? So you have to treat the patient. Treatment of the patient is with activated vitamin D in the case of osteomalacia, and you can give calcium ion supplementation in the case of osteitis fibrosa cystica, and you give oral phosphate binders in the case of osteosclerosis to prevent hyperphosphatemia. Also, surgically, you can do parathyroidectomy in a case where a patient has pituitary hyperplasia from resulting to hyperparathyroidism. The next bone mineral disease is going to be the Paget disease of the bone. It's a disease of uncertain etiology that is going to be characterized by accelerated bone turnover. So you have increased bone turnover. You are going to have there is bone destruction and there is bone destruction and bone formation at the same time. Is it clear? There is an uncontrollable bone destruction and bone formation at the same time. Is it clear? So that is why it's accelerated bone turnover. There is going to be a localized increase in osteoclastic activity and the vascularity engendering increased osteoblastic activity. Is it clear? So you have both an increase in osteoclastic activity because of the bone breakdown, and you have also an increase in osteoblastic activity resulting to the bone formation. Now, the osteoblast in turn lay down a bone that is going to be in a disordered fashion. Is it clear? So the osteoblasts are not going to since there is high turnover of bone, the bone that is being formed is not going to be a good bone, and the bone that is destroyed is also abnormal. Is it clear? That is going to give rise to thick, brittle, deformed, and painful bones. Is it clear? So the patient is going to present with pathological fractures and bone pain, and sometimes with signs of compressions such as deafness, in sensorineural deafness because of auditory nerve contraction, auditory nerve compression. And in this patient, you also have high alkaline phosphatase activity. The high alkaline phosphatase activity, just to tell you that what there is excessive osteoclastic activity, and that excessive osteoclastic activity can come because also of a hyperparathyroidism, though hyperparathyroidism is not usually associated with a case of Paget's disease of the bone. Is it clear? You can have high alkaline phosphatase activity. Now the treatment is mainly analgesic, and you have to use also biphosphonate because there's going to be excessive calcium ion in blood. So when you use biphosphonate, actually you are going to reduce calcium ion in blood. We said that in a case of hyperphosphatemia, you use oral phosphate binders, and typical oral phosphate binders include calcium ion in food, and also have aluminum ion in food. So from here we are finished with bone mineral disease, and we will go to the next tutorial. So we say thanks for your kind attention, and please don't forget to like and subscribe for our channel, Science Video Makers. Thank you.